for those of you that might have just joined, I have Dr. Foley, my new medical advisor for Learn, Look, Locate, and Leslie Yerger, who is a lobular breast cancer thriver who started her own mission to help women truly understand what she has gone through. She, like myself, had no idea that she had breast cancer, right, Leslie? And she wants every woman to know. No idea. Why don't you tell people why you do what you do and who you are? That'd be great.
You bet. So almost 6 years ago now, I was diagnosed with stage 4 lobular breast cancer. 2 months after an all-clear mammogram and ultrasound. Everybody says, well, then how did they find it? Well, it was what is called an incidental finding through just a routine DEXA scan that I got.
Wow.
Saw something weird in that, and then X-ray, and then CT, and then tests for multiple myeloma, which all came back negative. Finally, a bone biopsy, which revealed lobular breast cancer.
Wait, so, a what biopsy?
A bone biopsy.
How do you do a bone biopsy? I've never even heard of this.
Well, Dr. Foley can explain that better than I can, but what, from my perspective, is they numb it and they put a big needle in you and they take stuff out of your bone and test it. How about that, Dr. Foley?
That is basically what they do.
Yeah.
They attempt to numb it, but I think a lot of patients who have a bone biopsy will say it's still quite painful.
Yeah, it kind of hurt, but it was kind of like, they didn't put me out, but just like made everything, you know, just kind of like I didn't care for a little bit of time.
Yeah.
You know.
Yeah. Wow, I did not realize that. I mean, and so Leslie is on a mission, as am I, to make sure that every woman is educated about our experience, but really like in a way that is just very powerful. Sorry, guys, I'm having some issues with my phone here. I think the most important thing we want to address tonight is what is lobular breast cancer? Because even myself, I had no idea, you know, as I do my research every day, just understanding this particular type of breast cancer, you know, it's pretty aggressive. I was just, you know, doing a little more reading. And again, Dr. Foley, you had mentioned to me it's the tiger in the tall grass. How do you find it? How do you know you have it?
Well,
oh my goodness.
For less than 10% or approximately of all breast as developing asymmetry on a mammogram. Occasionally, it presents as a mass like ductal breast cancers, but the growth pattern is very different from the most common forms of breast cancer. Being ductal cancer, the cells divide and it grows concentric. 2 cells become 4 become 16.
It's hard to hear you. You come closer. Yeah.
The way ductal cancer proliferates, that's why lobular cancer develops differently. It sends out individual cells along lines. It grows like crabgrass, which we all know is very difficult to get rid of, right? But it is truly the tiger in the tall grass. It can be present for a very long time before it is diagnosed. And there's kind of like the vast majority of lobular cancers are not the aggressive ones. They're the low grade, slow growing, estrogen receptor positive breast cancers. But the biggest problem that I see with lobular cancer, that oftentimes, because it has been sneaking along, laying in the grass, like hiding among the density of the tissue, by the time we make the diagnosis, it can be quite extensive and may require a mastectomy for surgical treatment.
Yeah, I have a question for Dr. Foley about the way you describe the way it grows. So not a lump, because, you know, mine was never a lump. It was just kind of like an area.
Right.
You know, or a thickening that one doctor could feel, no one else really could. Even I couldn't. But is that part of the reason, the way it grows, more like a, you know, kind of like spidery, or, you know, like maybe long strings? Is that part of the reason why it will tend to metastasize faster, possibly?
Good question.
I don't think that's why it metastasizes, but I do think that's why it's harder to detect.
Okay.
Like, it doesn't feel like a lump. You said exactly what we see.
Yeah.
It feels like a thickening. Sometimes patients will just have this strong sense that something is quite different about their breast compared to the way their breast has been in the past. And to be honest, the most sensitive test for detecting lobular cancer is an MRI.
Mm-hmm. Yeah, which most people don't get.
Correct.
Yeah.
It can be
Right.
missed on a mammogram. It can be missed on an ultrasound. And this is where I would say patients can have an opportunity to advocate for themselves. If they feel like something is wrong and they are told your mammogram and your ultrasound are normal, they need to push and advocate for further testing with an MRI.
Yeah.
Let's talk about the thickening, because I featured a survivor from TikTok on Instagram, Debbie. I don't know if she's on, but she was very happy to get to share her story and the thickening. What does this feel like, guys? What is this? Is it like hard skin? What is it? Like some?
No, it just feels thicker. I mean, I think it's hard to explain. It almost maybe feels like bread dough.
Not painful? No pain.
I didn't have any pain at all, and mine was about 3 by 5 centimeter area,
which is significant.
Yeah, it's about, I don't know, maybe the size of a small egg or something like that.
That's it.
And as many of us will, our breasts are slightly different size, especially after kids and nursing and all this kind of stuff. And so I always thought, well, if I ever have breast cancer, it's going to be in the big one. It wasn't. It was in the smaller one. What's with that? You think if you have something in there, it would be bigger, but it wasn't. I don't think that's the way it really works. It's just this is just the way we think about it when we're lay people.
So many patients will say, "Oh, my breasts are so small. I'm sure my risk for developing breast cancer is less," or they'll say, "That's going to reduce my risk."
Yeah.
Neither of those things are accurate.
So with lobular, I was reading also the average age is usually like between 44 and 46. So young, is that correct? I mean, I'm seeing this
It's actually a little bit older than ductal cancer. So I would say it trends more toward the 50s, toward the mid 50s. We kind of consider it a disease of older women. That's hard for me to say because I'm getting closer to that. Yeah.
Yeah, so I was 55 when I was diagnosed. However, they thought it had been there for at least a decade. As much as was in my bones after it was ultimately found, they're like, that's been there for a while.
A decade, Leslie?
Yeah, because it was really slow growing. Like key 67, Dr. Foley, I don't know if you want to explain that, but it was like 5%. Which is a pretty low.
Yeah, the proliferation rate. That tells us how fast the cells are turning over. Yeah. So like I said in the beginning, like there is this like bimodal distribution of the vast majority of lobular cancers are these low grade, slow growing. I've even heard a pathologist one time call it sneaky carcinoma.
Mm-hmm.
It's sneaky. But then on this other side of the divide, you've got like the pleomorphic lobular cancer, which is quite aggressive and will metastasize earlier and will be refractory to treatment. So it's got two peaks.
I have a question. What does it look like? I don't know if I've shared this with you guys or anyone, that when they told me I had breast cancer before the biopsy, I was like, I want to see it on the screen. And they showed it to me before my biopsy. You believe this? So when I got my biopsy, I knew I had breast cancer. Go figure. But I could see the spider cancer-y stuff, right? What does it look like, Dr. Foley, on the screen if you're looking at it as a radiologist?
So it can have quite a variety of presentations. Like sometimes it will be a mass that's spiculated, that has that spidery appearance. But other times it will appear like thin wispy clouds. Like there's just some clouds over here, no clouds anywhere else. So if you see what we would call an asymmetry or a focal asymmetry an area of the tissue that is more white in just a specific localized area, that could be a concern, particularly if it's a new finding. If it's a new finding, we would call that a developing asymmetry. And just the fact that it's new, it's something that's changing, that elevates our concern that it could represent breast cancer.
So if the cells are turning over every 6 months and creating, these cancer cells, you might not see it until the annual mammogram. And so this is where, as someone who was like Leslie, they told me growing for 5 years. So this is why this disease is so complex and so puzzling. And I really wish more people would have joined tonight, but hopefully they'll come back and see this, because I get emotional. Awareness is lovely, but if we need to educate women on the sneakiness, the silentness, I was just sharing with you, Dr. Foley, my friend just got diagnosed with lung cancer. She had no idea. She's stage 4 lung cancer. Cancer, it can be so silent. But here's the problem with lobular and all my research is like, first of all, if you don't have someone's writing, absolutely sneaky, never missed a mammo. Neither did I. But I never did a self-breast check. So I'm going on and on about how do we educate women about lobular breast cancer outside of being like, I want an ultrasound. I feel like I should tell every woman to get an ultrasound no matter what. Because if we're all getting normal mammograms, and Leslie's got sneaky lobular, and I've got a walnut-sized tumor, the minute they did the ultrasound, they could see it. What are we supposed to do?
Well, Cynthia, I know you've shared before that you have dense tissue.
Yeah, so did
nobody ever told you that. And
Yeah.
Leslie, I know you do too.
Yep.
You both had dense tissue. So for what we should be educating and empowering women who have dense tissue, when you get your letter, look at your letter. As of September 2024, it will be required for it to say you are dense or you are not dense.
Yeah.
That's a year. But that's a year away.
Well,
Yeah.
we've already changed our letters. A lot of people are probably proactively changing their letters, but get your report.
Yeah.
Look at your letter, and if it says that you are dense, advocate for yourself and say, my letter says I'm dense. We've got to educate the primary care providers as well, because this is new. At least in the state of Arkansas, Arkansas has been slow to adopt supplemental screening with ultrasound. I started doing it when I came back home to practice in 2019, and it's been like trying to turn a cruise ship. Doesn't turn very quickly.
Yeah, when we work with women, we tell them you've got to look at your report. We call it check your chart, but it's looking at your report and looking to see what's really in there, and then advocating for yourself, because anything beyond mammography really isn't standard of care, and sometimes the referring physician doesn't read all the way to the bottom either, so we got to do it ourselves right now, because it's not happening automatically for us.
Yeah, but the problem is, I find, all of us that are doing this constantly, we're reaching the same people.
Yeah.
It's the mass public that is really scares me, because, we didn't know, Leslie.
Nope.
We were living our lives. Now we know, and we do this all day long. But I still believe the people, especially when I think of lobular, let's talk about, again, how it presents itself, because this is going to get out there. I want to post this everywhere, this conversation. How does a woman, if she's getting their clear mammograms, if she's like me, she didn't do one self-breast check. Not once. I don't have any family history. Never thought it would happen to me. Help us out, Dr. Foley. Help us out.
Cynthia, you're in the majority. 85% of women diagnosed with breast cancer are the first person in their family to have breast cancer. So we really need to educate women that it's not all about family history. We put so much emphasis on family history. And there is an area where it's important to know the family history, even with lobular cancer. There is an association with lobular cancer and a specific gene mutation, the CDH1 gene mutation. That particular gene mutation is deadly. It causes hereditary gastric cancer.
Yeah.
That's another silent killer. Like, it can be far metastasized before you're ever diagnosed with it. So if there's family history of lobular cancer and family history of gastric cancer, you really need to see someone who can offer you genetic testing and test you for that specific mutation.
I have a question for Dr. Foley about CDH1. Okay, so I got diagnosed with lobular breast cancer, and then I got the genetic test, of which CDH1 is one of the things that they test for, or at least in my panel, and it was negative. Okay, but then when they sent the sample of the cells off, it came back
Positive
with a mutation
CDH1.
of CDH1. So can you tell me the difference between that and, please?
Yeah. So,
okay.
your genome, the way I explain it, we're $1. We get 50 cents from our mama, we get 50 cents from our daddy,
yep.
And that makes our dollar that is our genetic, what we're made of, right? So you don't have a gene mutation in your chromosomes, but the tumor has a mutation that's positive for that gene. Tumors mutate. They're very
okay.
very clever. They want to continue to thrive, and so the cells in the tumor mutate, and sometimes that's why a treatment that was effective stops being effective.
Yeah.
That's when patients have recurrences.
Okay. All right. So I don't have the hereditary gene, but then when the cancer mutated to become cancer, it carried that CDH1. And then my doctor said, well, I don't have to know anything else except when I look at this report, I know it's lobular because it's CDH1.
CDH1. Somebody's asking, what is the mutation? I've never even heard of this. CDH1.
It's not a common mutation, but it is one of those mutations that it's really important. If you undergo genetic testing and you test positive for a mutation, you have got to share this information with your family members and encourage them to get cascade testing. I have several patients in the panel of patients that I care for that have the CDH1 gene mutation, including one of my mother's dear friends, who her history is that she had cancer in one breast many years ago, treated for that successfully. She was getting yearly mammograms with us, and we found a new area that was distorted on her 3D mammogram, and that turned out to be an additional, it was positive for breast cancer. She had ductal cancer. So just because you have a CDH1 mutation doesn't mean that you'll absolutely develop a lobular cancer. But we were following our protocol. Any woman who is diagnosed with a second breast cancer, if you have not had genetic testing, you need to have genetic testing. So we were following the protocol. We tested her. She tested positive for CDH1. So that now punches her ticket, and she can have endoscopy. She can have some a higher level of screening for this hereditary gastric cancer, which is deadly. On the other end of the spectrum, I have a patient that she has the mutation, and about 8 people in her family also have the mutation. And several of them have prophylactically had their stomach removed so they won't develop. They're becoming previvors. Yeah, they're becoming previvors of gastric cancer.
Wow. So
does that apply to the intestines too, or just stomach?
I think it's primarily gastric, but it could be small intestines as well.
Okay. Wow.
See, somebody, thank you for commenting. They're BRCA2 and they did not know about this mutation. This is so informative. This is just so incredibly helpful. Thank you, Dr. Foley. I mean, this is just powerful information that women need to know. I mean, I'm still puzzled by lobular in the sense that I feel like, well, first of all, the word lobular, like, explain, in my research, it's coming from the lobules where the milk glands are. Is that correct?
Yes.
So let's talk.
It comes from the part of, the breast is really composed of 3 different types of tissue. There's the lobules that produce the milk. There are the ducts that carry the milk to the nipple. And then there's that connective tissue, or, it's like what holds it all together. The skin and the Cooper's ligaments that attach it all to the chest wall. So the vast majority of breast cancers originate within the duct. They're ductal in their origin. Lobular cancers are the minority. They account for 10% of breast cancers. And so they're not forming, they don't typically form behind the nipple. They tend to be more peripheral out into the breast tissue. And because of their cell growth pattern, this laying down cells like pavers, this is the reason it's not forming a mass. It's not going to feel like a lump. It just may feel like an area that's thicker, that's more coarse or heavier.
Wow.
And on the mammogram, it's tricky because it doesn't form a mass. It's forming this developing asymmetry. I think the trickiest thing is that, say a woman hasn't been getting a mammogram, or maybe she's had a huge gap. Like she got mammograms a long time ago and now she started up again and we don't have the old films for comparison. If you've got one of these wispy cloud areas that's in a focal zone, like sometimes people will assume, well, that's just her pattern of breast tissue.
It's so interesting.
Because
Yeah.
it doesn't form a mass.
So is it always not a mass? Could it be?
No. Yeah, it can be a mass. It's just not as common. I have a patient in my panel that I've diagnosed with lobular cancer in the last few weeks, and she had dense tissue. She was not taking hormone therapy, and because she had dense tissue, we did the supplemental ultrasound, and I did note on the mammogram image, like there was this kind of developing asymmetry, and when we looked with ultrasound, that area did not appear cystic. It was like on Sesame Street. Which one of these is not like the other one? It just looked different, right? And we biopsied it, and it was a lobular cancer.
Wow.
Hers is low grade, and it's estrogen receptor positive. So she can be treated with anti-estrogen therapy.
Question about that. Is lobular always estrogen receptive?
No, but the vast majority of lobular cancers are positive for estrogen receptors.
Got it.
I want to open up to the audience here. We're getting quite a few people popping on. Do you guys have questions before we keep going? Let's see if there's any questions. I just am still baffled, as always, on how we're supposed to get women to, like, I should have gotten ultrasounds, and I had a tumor. So I just don't know how a woman's going to advocate for herself, not even knowing, first of all, the symptoms and then the sneakiness of this. I mean, why are we not all getting ultrasounds? This is ridiculous.
Well,
I mean,
I'm not sure that an ultrasound is going to benefit a woman with a completely fatty replaced breast, right?
Okay.
If she's in the density A category, or if she's got really wispy thin clouds like a density B, I'm not sure that those women really would benefit from the ultrasound. I don't know that the ultrasound is going to give us more information.
Okay.
The way I explained that, like, I think one of the ways we could turn this cruise ship is to get women to understand that density is not something you can feel.
Yeah.
Density is not felt. It is determined on your mammogram. The only way to know what your density is to look at your report, look at your letter. So we can empower women to understand what is being conveyed in that report. And if they fall into the dense category, then they definitely need to get an ultrasound. But one of the ways I describe density to my patients who think they might need an ultrasound when they don't have dense tissue is they have a glass bottom boat on a glacier lake. I can see every pebble, right? I can see every little bump. Now, I have dense tissue too, like both of you, because 40 to 50% of women do have dense tissue. So my breast tissue is more like the Arkansas River. It's murky. You could hide a dead body in there, like a cancer. I'm going to practice what I preach, and I had that supplemental ultrasound last year. I had to pay out of pocket for it, and I had 16 cysts on my ultrasound, and I could barely see one of them on my mammogram.
So let me ask you, I have a question for you. All this, as far as advocating, reading our letters and all that, I must tell you guys, when I got diagnosed, I was determined to find out who my radiologist was because I felt like she saved my life. She's behind the scenes. I had no idea who she was. And I got a hold of her via text, and I couldn't thank her enough. And then I kept saying, look what I'm going to do with this. I'm going to start this whole organization, da da da. But why are we not having a chat with, I know you're super busy, but is there, you see what I'm saying? You see where I'm going, and Leslie, maybe you know more about this as well, but that patient connection with the person that's actually seeing your report. I mean, I hear what you're saying, but you take a busy woman who's checked the box, 40 years old, you know, she's her first mammogram, she's got like 5 kids or whatever she's got, busy life, full-time job. She doesn't know. My friend just sent me via text her report. She had no idea how to read her mammogram report. And now because of what I do, and Leslie, I'm sure you've helped a lot of people.
Yeah.
Most women are clueless.
They don't know they're supposed to, you know, like that. Start there. They don't know that they're supposed to look.
That's right.
You know?
So I ask you, you know, how do we stop this? How do we save lives? How do we change how the world is dealing with this disease? It's sneaky, it's silent, it's hitting young women. There's no symptoms. It's ridiculous. So then I hear you speaking and I say, it starts with you guys, and it starts with, in my opinion, the gynecologist. I'm like angry with my gynecologist. I'm like, you never taught me any of this. I don't know.
But I don't think anybody taught the gynecologist about dense tissue either. I had an opportunity in the spring to speak at a conference for gynecologists, and I gave talks, like an update on breast imaging and breast cancer detection, what they needed to know. And we assume that everybody knows what we know in our field.
Yeah.
So I'll give you my great example of this. Like, I had a slide that said, breast MRI is contraindicated in pregnancy. That is a fact. We do not give the gadolinium contrast agent during pregnancy because it's a potential teratogen. Like, it could potentially cause a birth defect. Every radiologist knows that. It was just a quick in my slides, and I was on to the next thing I was talking about. At the end of the session, all of these gynecologists were crowded around me like it was story time at the library. And one of them said, hey, I have a dumb question. And I said, there are no dumb questions. What's your question? And they said, why is gadolinium contraindicated in pregnancy? I've never heard that before. So
wow, a gynecologist?
Yeah. And several of them chimed in like, yeah, I've never heard that. So we can't assume that they know the ins and outs and then, you know, the little details of our specialty. I don't assume that they know that.
Yeah. How do we get a mandatory CME for all OB-GYNs and all PCPs and probably nurse practitioners? Like, how do we do that? Because, you know, like get you in front of all of them and they will all know this. How do we do that?
I'm not sure. I've been doing quite a bit of lecturing, so, you know, one small group at a time.
I know, but I want everybody to hear you, not just the people in the lecture hall.
But a lot of those lectures are available as enduring material that's free to access. Like, one of the organizations that I've done a lot of work with is World Class CME. Yeah. WCCME. They have a really robust website with lots of different CME lectures, and people can go on and watch the lecture and they can get a credit for free. There are a lot of different topics about radiology, OBGYN, ultrasound. I mean, it's really an amazing resource.
But you know what? Wow. This is so enlightening for all of us that are on here and those that are listening. We need to know this, that it's really important that we understand that maybe the gynecologists don't really even know all of this.
Right.
You know?
Right.
And
you asked me, why don't I meet with every patient? Ladies are busy. A lady with 5 kids who is running in to get her mammogram, she doesn't want to wait. She doesn't want to stop. She's got something else to do. Sometimes people don't want to talk to me because they're busy.
Yeah, and does that fit? Could that actually fit into your workflow? Because that's a lot of extra time for you. I mean, you might want to do it, but do you even read them right then and there? Well, things are crazy.
Yeah, in the beginning, when we just started this breast center, and you know, she was a baby breast center, I did every single patient, and I even hand wrote them thank you notes for trusting us with their health. Yeah.
That's cool.
Because we were an upstart. Like we were new. We were the last, center into the market. But today I had 18 patients on the schedule for screening, and they did what we would call screen and go.
Yeah.
They got their screening and then they scooted out the door.
So hold on one second. Nurse navigators help in some situations.
Yeah, that would be great to have them know all this too.
I want to share with you, and one of the reasons why I do learn, look, locate, the way I do it is to grab people's attention. And I had a genomic company have me design a brochure in my edgy, colorful, really patient-friendly way. And the whole sales team is running around with this. And so what I would love, this is my vision, and I'm sure, Leslie, you can attest to it, is when you leave, we hand them something quite beautiful that they will look at and say, don't just take, even on my mammogram page on my website, ladies, take your mammogram seriously. This is serious. This is not a check the box. It is a very important, and Dr. Rosen would say, we have the tools for this type of cancer. And that's powerful, right? There's not a lot of, we can't really, I don't know, can we screen for pancreatic? Can we screen, there's certain things we just can't. I'm just sort of throwing that in.
It's a lot harder. It is a lot harder to screen for pancreatic, but we do have tools at our disposal. It doesn't have to be the radiologist that tells the patient what their density is. Yeah. We have AI software that we are utilizing when we're reading screening mammograms that do a density assessment. Is it a perfect tool? No. It gets it wrong a minority of the time. Right. But the majority of the time, when the technologist does their images, it creates that report to tell them what the density is, A, B, C, or D. I am happy for the technologist to share with the patients that they are dense, and then to encourage them, like, hey, you had your mammogram today and you're dense. Like you probably want to schedule an ultrasound at least for next year, if not before then. So I think the radiologist can empower the technologist. The technologists,
that's a good way to go.
Have been doing this a long time. Yeah. Like they know the difference between dense and not dense.
Right. Yeah. Well, let's take it even further. I mean, even just educating A, B, C, D. I mean, what's so cool is my friend showing me all of this, her report, and I can sit here and go, you C or D, you need more, right? But let's go to BI-RADS.
Okay.
Let's talk about that.
Let's talk about BI-RADS. Well, I'm a big fan of BI-RADS as a breast radiologist. I am kind of like I'm a very straight-laced, by the book kind of person. And I feel like if we all leaned into using the BI-RADS the way it was intended to use, to be a standard lexicon, a standard set of words that communicate what we're seeing, if we had fewer people giving it their own flourish, and they used the standard language, and they created structured reports that said, reason for exam, type of exam, views, density, findings, impression, recommendation. Like a lot of people are just free texting, or they have a template. And I hate seeing these reports that have this huge disclaimer at the bottom, like this huge paragraph that says mammograms may not find your cancer. Like we don't put that on.
I've seen a lot of those.
We don't put that on our
standard report.
That's horrible.
Structure.
That's just like saying
false
we
positive.
might fail, and we don't care if we might fail.
That's right. He had the same thing, and I was like, what is this? Another thing, I know we can go off on this, is 2D. I was getting 2D mammography. Would a lobular breast cancer be picked up on a 2D mammogram?
It could, but it would really have to be pretty far advanced. Like it would have to be sizable. It would have to be really a fairly dramatic appearance.
Okay.
But it's
we do have
more likely to be detected on a 3D mammogram, because you're looking at the breast structure in a finer detail. We're able to pick up, lobular cancer as this developing asymmetry. Oftentimes it does have distortion associated with it, and 3D mammography is great at seeing distortion.
Yeah. So Gaga Girl asked a great question that I actually need the answer to. So thank you so much for this. She says, after mastectomy, how are we to monitor recurrence in the chest wall? What is our care moving forward? I have not had one screening on my flat chest. Thank you, Gaga girl, for this. And you know, I'm in a new town getting horrible follow-up care. So what do people do? And with that question, can you have invasive ductal like I have had, and then can you have lobular just in your chest wall later?
You could. Yeah, you could have a completely, like some people have 2 different tumor types, or they have ductal cancer with lobular features. Like, it can be a mixed bag. I would say the follow-up of patients who have undergone bilateral mastectomy is somewhat controversial, right? There's not a standardized approach to follow-up of patients who have undergone bilateral mastectomy, because the thought is you have reduced your risk to less than 10%. But if it is going to recur, you're right, it would potentially recur at the chest wall. I think the things that you can control is you could do a self-exam. You know, feel yourself on the first. Check yourself for any kind of pain. Still not
doing it. Would you believe after all I do, I don't do it.
And making sure you get an exam by a physician or, you know, nurse practitioner, somebody that you really trust once a year. I think getting a clinical exam of your chest wall by either your surgeon or your gynecologist or your medical oncologist, somebody should be examining your breast. And then if you feel like that's not enough, then I would consider either ultrasound or MRI.
But what if you don't have any breasts?
We still, well, okay, I'm just going to put this out there. Not all mastectomies are created equal.
So there still could be tissue left,
Correct.
Is what you're saying.
Yeah.
And that's where it would recur, if it's going to recur there and not possibly, you know.
I mean, sometimes it's more of an anterior lobotomy.
Is there no screening? Like, well, I mean, you just mentioned MRI, which I guess would be that, but
I think you could, the other alternative would be ultrasound. A lot of patients, like Leslie, you know, you came into the game with stage 4 disease. Yeah. A lot of patients that have stage 4 disease that are thriving with, you know, the modern medical advancements are getting other types of scans. You said your cancer was picked up on a bone density test
scan.
On a DEXA scan, right?
Yep.
So a lot of the patients who have stage 4 disease are getting CT. They're getting a CT of their chest, abdomen, and pelvis.
Yep.
And hopefully the radiologists that are reading those scans are tuned into what a recurrence could potentially look like.
Yeah.
And if they pick something up, they're going to refer them for an ultrasound.
Yeah. I get PET CTs, and that, you know, when I got the first PET CT, the lobular showed up like, you know, a big goose egg in the breast. It's the first time anybody really ever saw it on imaging. Of course, now with the treatment, it's basically not there, or it's not showing up because it's not active. Thank goodness right now. What else is happening? Yeah.
Does BI-RADS, I have a post, sorry if I'm it says, what is your BI-RADS score, your mammogram, know it? Is this something that a woman should typically know? I mean, we're trying to get them to understand their density score, but is BI-RADS?
I think BI-RADS is pushing the envelope. I mean, can women understand the BI-RADS? Absolutely. There are 6 categories. BI-RADS 0, you're reading a screening mammogram, you see something, you want the patient to come back. Okay, so it's BI-RADS 0 is incomplete, needs additional evaluation. What you're hoping for is a BI-RADS 1 or 2. BI-RADS 1 is negative. We don't see anything. That we don't even see a benign finding that we want to describe. BI-RADS 2 is maybe we see benign calcification, or we see a lymph node in the breast tissue, and we're going to describe it. If we're going to describe anything, we should give it a classification of a BI-RADS 2.
Okay.
BI-RADS 3, it means that there's a less than 2% risk of you having breast cancer, but it's still not 100%. It's 98% likelihood that everything's okay, less than 2% that you have breast cancer. And BI-RADS 3 are those patients that we're going to follow more closely for a defined period of time. It's typically 2 years. We typically will follow them at 6, 12, and then 24 months. And then if the finding that we're considering probably benign, if it remains stable at the 2-year mark, we let the patient return back to screening. BI-RADS 4 is suspicious. And there are subsets of 4. There's A, B, and C, different levels of suspicion. BI-RADS 5 is highly suggestive of malignancy. This is when we're saying, I'm 95% sure this is breast cancer. If I do a biopsy and the biopsy result doesn't say that this is breast cancer, I'm essentially committing the patient to have surgery because I am that confident that this is breast cancer. And BI-RADS 6 is a patient that we know has breast cancer. They haven't undergone definitive surgical treatment. They're undergoing some type of treatment, but they haven't had their surgical treatment. Some patients will, say with a low-grade tumor that's estrogen receptor positive and they're on anti-estrogen therapy, they may live in the BI-RADS 6 neighborhood for the rest of their time.
Mm-hmm. Wow.
I had a BI-RADS 4 a year after my diagnosis in the other side in my lymph node. Can you imagine? After my surgery,
Terrifying.
And everything was done. It was beyond. It was a suspicious lymph node. And that is when I learned about BI-RADS. So all of us who've been smacked with this, I'm sure, are obsessed with reading our reports. So we read this before we know what this means. And that's how I learned the 0 through 6. And I was like, 4 is not good, right?
No, 4 just means it needs a biopsy. And truth be told, so that lymph node, was that lymph node positive?
It was on the other side, not where the tumor was. And it's a long story. I had a skin reaction. I was on some medication, and the oncologist felt that that medication was causing it was negative. It was negative.
Okay.
So everything was okay. But that's another thing I want to talk about, that the body can react, the lymph nodes and all of that can, whack out and cause some of these false positives or whatever. Yeah, but so I think really I want to be respectful of everyone's time here. We've been going for a long time. It's such good conversation. You're the first one I've really had. I never went live with Dr. Patel. She's my other medical advisor for radiologists. I think she's wonderful. But having these live discussions for the mass public, just so everyone knows, I will be editing this into bite-sized, 1-minute digestible pieces of information and put them all over the Learn, Look, Locate platforms. This type of information is priceless. It is life-saving. It is valuable. And we need to work together to talk more so that we reach the woman that's breastfeeding, that thinks she has a clogged milk duct. I have so many followers, these young women.
So many times. I've heard that so many times. But I do want to emphasize,
yes,
in the BI-RADS 4 classification,
yes,
if you think about it, the vast majority of the biopsies we perform don't end up having a breast cancer diagnosis. So only about 20 to 25% of the biopsies we perform yield a diagnosis of breast cancer. So I would encourage women, like if you have been told you have a suspicious finding and a biopsy is recommended, don't start planning your funeral. Just understand that's another data point, okay? We're gathering more information so we know what we should be ultimately doing for you.
To that point, we are going to work on some great stuff together, Dr. Foley, on biopsy, the biopsy experience. All aspects of it is so very important in the journey. It is the beginning, and it could be, in a good way, the end. Someone gets the biopsy and everything's fine. Or it could be the start. So we do want to talk, if it's okay with you, I'd love to go live with you on, biopsy, all in all.
Absolutely. Sticking people with needles is one of my superpowers.
And what's interesting about that is I think most people don't even know that the radiologist is the one who often does the biopsy.
Yeah.
Right.
Yeah.
Well, I do think, unfortunately, there are some women out there that get a surgical biopsy instead of a needle biopsy, and they don't understand the difference. They don't understand that that's really not what should be happening. There are the number of cases that I assess and say, I'm not going to biopsy this. I think the surgeon should. It's a very small percentage.
Okay.
I biopsy 99% of the things that I find that I think warrant a biopsy.
Tell us the difference between the two, though, because I think, you know, that's an interesting point.
So a needle core biopsy is a minimally invasive test that allows us to get a sample of the tissue, and then we send the tissue off, and the pathologist analyzes it and determines, you know, what it is. Like, is it breast cancer or not?
Mm-hmm.
There's very little downtime. You're not put under anesthesia. We do this under a local anesthetic. Is it 100% comfortable? No, I
can tell you
I
that.
have had a breast biopsy myself as a patient.
Yes.
For me personally, when I'm performing biopsies, I place a clip to note this area that I've taken the samples from. So it's like a paper trail. It's like when we learned about government and the checks and balances. It's like, I see this on the mammogram. I think this on the ultrasound matches. I biopsy it. I put a clip. My expectation is that clip sits where that area was on the mammogram. Mm-hmm. Sometimes they don't match up perfectly, and you've got more than one thing going on, right? Mm-hmm. So those checks and balances are really important. The difference, surgical excisional biopsy patient is put to sleep. This happens in an operating room. You're put under anesthesia. There's an incision in your breast that is sutured together. With a needle biopsy, there are no sutures. We use steri-strips or dermabond glue to close the very tiny opening we create to permit us to use a needle to get the sample. So the biggest problem with going to a surgical biopsy first is, if it's positive, you will have a second surgery more than likely. Yeah. Because you're not going into that surgery planning to get negative margins, to sample lymph nodes. If it's positive for invasive disease, you're definitely having a second surgery to sample your lymph nodes. And my goal is for, you know, like, I don't want anyone to have breast cancer. But if you have breast cancer, I want to find it early. I want the process to be streamlined for you so that when you have your surgery, it's one step. It's one surgical procedure.
Yeah, that makes sense.
Let me ask a question about biopsies, because I've seen a lot of this questioning on whether or not, when you're taking the biopsy out, are you sloughing off cancer cells that could be floating around?
Okay, there is a theoretical potential for that, but those potentially left behind cells have no blood supply, so they don't proliferate. We've been safely doing needle biopsies in the breast for decades. So, I mean, that is one of the big myths, where some patients will say, I don't want to have a needle biopsy because you're just going to spread my tumor. It doesn't really work like that in breast cancer.
So the tumor really needs that blood supply to keep multiplying. Yeah. Is that correct?
It creates its own blood supply. They call it, you know, neoangiogenesis. Angiogenesis meaning developing blood cells or blood vessels. So tumors create their own blood supply. They take over, kind of like
I don't know about you, Leslie, but I am reliving my biopsy right now. I mean, you know, it's so far gone, but just having this conversation, I mean, I was so freaked out. I mean, it's just.
It was hard. And then, you know, so what was interesting with mine is, since it was lobular, back to the lobular thing now.
Yeah.
They had a really, 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 really hard time finding it with the ultrasound, and so they spent like 40 minutes trying to find where to biopsy. They were getting frustrated about it. Finally did, and then the biopsy happened. But I was just like, wow, how do we even know something's there when it's hard to see? But yeah, and then, you know, they took several samples, because I was in a study, so they took more than one sample.
We almost always take multiple samples, because we don't want there to be sampling error, where the part that we sampled is benign, but that doesn't really represent the total lesion.
Would that be particularly true of lobular, since it's kind of like spread out and not a lump, or not?
Not necessarily.
Okay. Interesting. Okay.
Well, ladies, we could talk for hours. I mean, this is so fascinating to me. I don't know why I'm just so drawn towards learning and understanding. I think because this happened to me and Leslie, those of you that don't know, Leslie has dedicated her life as well, like me, to educating women to stop this, to get the information out there. She started a wonderful organization called My Density Matters. So go check her out, give her a follow, please. She works tirelessly as much as I do. We believe in this, and we work together. We're two organizations that, you know, really believe very strongly in making sure women check their chart. That's how Leslie calls it, and educates themselves.
Yeah.
This is
collaboration is where it's at, man. If we can't collaborate to save women's lives, then, you know, we got a problem.
Yeah.
The way
And there's a lot of that going on social. I think people need to really swim together in the same pool, because we really, you know, older, younger, different groups, this is, you know, this breaks my heart. I have a 23-year-old daughter, so these young organizations, we should all work together, because we want to help the young women. We want to change the generations and how this is perceived. I might do it a little edgy and weird, only because I wish I had this. It would have stopped me from scrolling on platforms that I hung out on, something to grab my attention, because we all don't think this can happen to us. You know, unless your story being smacked with stage 4 out of the gate. I mean, you know, we're driven by some of our anger, I would imagine too. I mean, this is ridiculous. And that's what drives me every day. This is absolutely ridiculous. So we are going to continue to work with Dr. Foley, who's been so kind and so compassionate. You're busy, you have your own life, but the fact that you and all the medical advisors, and Leslie, your medical advisors, care so deeply about women's health and see the gap and the problem that's going on here. It's a big problem.
Yes,
So
it is.
I'm honored to have both of you here this evening, and this will be on my Reels grid. I will share it with both of you, so if you want to share it with your followers. And for those of you that hung on the whole time, we really appreciate it. We know you're busy, and tomorrow I'm going live on inflammatory. Oh my God, this one is just unbelievable.
Yeah,
it's crazy. Then Paget's disease. I mean, I'm going as deep as possible, because awareness is more about the different types and the education, and that's how I see it. Real last question, can you see inflammatory on a mammogram?
You can. So the breast is going to be less compressible.
Okay.
It's going to be like snugged up to the chest. You might just see that the skin is thick, like it's really thick on that side, and maybe the lymph nodes are enlarged, but you can see inflammatory on a mammogram. And sometimes the clinical presentation is very subtle. It can look like just a very light sunburn. Like you can see redness. I am loving this website about the lemons, like knowyourlemons.com, where they've taken citrus, they've taken lemons, and they've shown the different types of presentations of what this could look like. And I think by showing it with fruit, by showing it with lemons, it's a little less scary, but that's what the tissue looks like. When somebody's nipple is deviated, or that it has that orange peel appearance, like the peau d'orange. You see that with inflammatory as well. Yeah.
And speaking of websites, we're going to be working on a page together on all of what you do on learnlooklocate.com, on density, on ultrasound,
on biopsy, high-risk screening.
Yeah. We got to get the women ahead of all of this. That's, you know, that's the ultimate on top of everything else. So ladies, thank you so much. It's wonderful.
Thank you for having us.
Yes.